Fast-acting vitamin D receptor agonists for the treatment of IACC conditions, infection-associated chronic conditions. Calcitriol versus paracalcitol, Part 4. In this YouTube, we continued the discussion about the possible repurposing of paracalcitol, 1,25-dihydroxyvitamin D2, for the treatment of COVID and long COVID. In this YouTube, we will review recent and historical papers which indicate the benefits of vitamin D receptor agonists, particularly paracalcitol, for the treatment of kidney disease, including various types of renal inflammation. The green information vectors in the center of the slide indicate that there are two main axes that we are currently speaking about. One is the suppression of ferroptosis. This is accomplished by stimulating vitamin D receptors, which upregulate the master anti-inflammatory antioxidant transcription factor NRF2, which in turn upregulates a key antioxidant enzyme, GPX4. GPX4 is an enzyme which utilizes an electron and energy from glutathione to chemically reduce reactive oxygen species as well as peroxidated lipids, which are the upstream drivers of the programmed cell death pathway known as ferroptosis. The second key axis is a pathway which has been recently discovered. Activated vitamin D receptors upregulate an enzyme known as CYP2J2. This is an epoxygenase. An epoxygenase is an enzyme which puts epoxy groups, in this case, on a pro-inflammatory lipid, arachidonic acid. The addition of an epoxy group to arachidonic acid converts it from being a pro-inflammatory signaling molecule to an anti-inflammatory signaling molecule. And the group of lipids which result from this epoxygenation are known as EETs, which is an abbreviation for a long term, epoxy-icosatrienoic acids. EETs have multiple effects, including changing the behavior, the epigenetic trajectory of macrophages from pro-inflammatory phenotypes, which are known as M1 macrophages, to anti-inflammatory macrophage phenotypes, which are known as M2 macrophages. And this process of shifting the epigenetic trajectory and cell behavior is known as macrophage M2 polarization. It's a polarization of the epigenetic trajectory of these cells, how they behave. Macrophages in their M2 phenotypes promote anti-inflammatory activity and the healing of injured tissues. In doing so, they help suppress the inflammatory damage being produced by diabetic nephropathy. The takeaway concept of this YouTube, as well as prior YouTubes in this series, is the use of paracalcitol to stimulate vitamin D receptors. The clinical goal is to boost the physiology of remission from these inflammatory states. And here are the links to the first three portions of this YouTube series. How does this pertain to long COVID in particular? Long COVID is one of many IACC conditions, infection-associated chronic conditions. As we mentioned, during inflammatory states, arachidonic acid is produced. It's a pro-inflammatory signaling molecule. Arachidonic acid is processed by multiple types of enzymes to produce several classes of pro-inflammatory lipid metabolites, prostaglandins, leukotrienes, and thromboxanes. In contrast to these pro-inflammatory pathways, there is a key anti-inflammatory pathway which is mediated in part by this key enzyme, CYP2J2, which epoxygenates the arachidonic acid, forming EETs, which are anti-inflammatory. How does that pertain to long COVID? Particularly the microclots, which lodge in microvasculature and create ischemic reperfusion injuries, very devastating physiological actions on many organs in the body. How can the upregulation of an epoxygenase, CYP2J2, impact the physiology of long COVID? To help answer that particular question, it is useful to look at the paper on the lower left of this slide, which was published in 2022. Proteomics of fibrin amyloid microclots in long COVID, post-acute sequelae of COVID-19, PASC, shows many entrapped pro-inflammatory molecules that may also contribute to a failed fibrolytic system. There is an update to this research published in 2025 in the Journal of Medical Virology. A figure from that paper is in the upper right, showing a long COVID microclot. This paper reports that neutrophils, which have discharged in the formation of a neutrophil extracellular trap, which is composed of a discharge of chromatin from the activated neutrophil. That extracellular trap of chromatin complexes with platelets and forms a very compact and stable microclot, which contains these pro-inflammatory molecules. It should also be mentioned that it's likely to contain the remnants of virions that were captured in the process of the formation of the microclot. So these pro-inflammatory microclots have impacts that extend beyond the acute COVID-19 event. And this is illustrated from a figure in the 2022 paper. Panel A shows a activation of fibrinogen linked with the spike protein in the vicinity of platelets, and the pathological cross-linking forms fibrinoid microclots. Those would be normally degraded by fibrinolysis as the body returns to health. However, in the case of long COVID, panel B, this results in a persistent long COVID condition, which is characterized by failed fibrinolysis, the lysis of the microclot, fibroclots, and hyperactivated platelets. These aberrant pathways result in the formation of amyloid fibrin microclots, which block microcapillaries, produce low tissue oxygenation, and promote thrombotic events. This results in general hypoxia of impacted tissues. In parallel, there are additional pathologies listed in panel C: dysregulated antibodies, dysregulated proteins that govern cellular function, and dysregulated liver proteins. Focusing now on dysregulated proteins that govern cellular behavior, one of the key cell types that will be impacted by microclots and the hypoxia they are producing are macrophages. And just to the lower left of the long COVID microclot is an M1 macrophage, a pro-inflammatory macrophage. And macrophages play a central role in long COVID pathophysiology. This is a review from 2025. How is it possible to suppress the pro-inflammatory, tissue-destructive M1 macrophage phenotypes and promote the formation of M2 macrophage phenotypes, which are anti-inflammatory and a phenotype that helps promote tissue repair? That brings us back to vitamin D receptors by stimulating vitamin D receptors with an agonist such as paracalcitol, 1,25-dihydroxyvitamin D2, abbreviated 1,25D2 for short, stimulating vitamin D receptors, upregulating the cytochrome P450 enzyme, CYP2J2, an epoxygenase, which puts epoxy groups on arachidonic acid, forming a class of anti-inflammatory lipid molecules known as EETs. And these EETs help suppress macrophage-mediated tissue damage. I would now like to change the narrative to link the benefits of stimulating vitamin D receptors to upregulate the production of EETs, epoxy-icosatrienoic acids, these anti-inflammatory lipids, as a means of suppressing tissue inflammation, chronic inflammation that's being produced in IACC conditions, particularly long COVID. So this is looking at the information landscape on PubMed. If you look for EETs, or epoxy-icosatrienoic acids, and renal, there's 33 papers. Here is a selection of some salient references for our discussion of long COVID. Arachidonic acid metabolism as a therapeutic target in acute kidney injury to chronic kidney disease transition. This is very pertinent to the transition from acute COVID to long COVID, how long COVID impacts renal tissues. Polyunsaturated fatty acids in kidney diseases, navigating the fine line between healing and damage. A novel role for cytochrome P450 epoxygenase metabolites in septic shock. Orally active epoxy-icosatrienoic acid analogs in hypertension and renal injury, and epoxy-icosatrienoic acid administration or soluble epoxy hydrolase inhibition attenuates renal fibrogenesis in obstructive nephropathy. Now shifting to a combined narrative where we will discuss the metabolites of arachidonic acids, those that have been processed by CYP2J2, how these EETs can alter macrophages, shifting them from M1 to M2 phenotypes. What about the roles of M1 macrophages in long COVID? First, a report from the Center for Infectious Disease Research and Policy, CIDRAP, at the University of Minnesota. This is March 20th, 2026. Up to 60% of healthcare workers may have long COVID 4 years after infection. We demonstrate a nonlinear decline in PASC-specific symptoms over time, with up to 60% of individuals still reporting symptoms after a median of almost 4 years after ancestral SARS-CoV-2 infection. Comparative analyses showed that the risk of developing PASC is highest after infection with ancestral SARS-CoV-2 and decreases with subsequent variants, the study authors noted. And again, this important review from 2025, the central role of macrophages in long COVID pathophysiology. Sidebar comment. When discussing the behaviors of macrophages, whether they are in the pro-inflammatory state or the anti-inflammatory tissue healing state, depends on soluble factors being released in autocrine, paracrine, and endocrine pathways. Some of these are derivatives of arachidonic acid. They have been epoxygenated and are now known as EETs. An AI overview which involves this review. In long COVID patients, M1 macrophages, pro-inflammatory, remain activated and, quote, trained into a chronic inflammatory state due to persistent SARS-CoV-2 spike protein reservoirs and epigenetic changes, sustaining long-term immune dysregulation. These cells continuously produce inflammatory mediators, contributing to ongoing tissue damage and systemic symptoms. Sidebar comment: this AI overview fails to recognize additional COVID toxins like the envelope protein or COVID RNA, which are also contributing to inflammatory states. Also, the role of microclots in persistently activating macrophages. So how can these inflammatory states be resolved? Again, this comes back to upregulating anti-inflammatory pathways, including the biosynthesis of EETs. And one way to do that is with vitamin D receptor agonists such as paracalcitol, 125 vitamin D2. So utilizing paracalcitol to stimulate vitamin D receptors, it is now known that this upregulates this epoxygenase enzyme, CYP2J2, which converts arachidonic acid into EETs. These EETs shift the epigenetic trajectory of macrophages from M1 phenotypes to M2 phenotypes. How important is this? It's important to recognize that COVID and long COVID involves kidney damage and probably chronic kidney inflammation because toxins like the S1 fragment of the spike protein become localized to the kidney and can persist for months. And so paracalcitol has a long history of being an renoprotective agent and an agent that can also suppress ongoing renal inflammation. How bad is the damage that's being done to the kidneys? Here are some key references. Paper from 2024. Kidney damage associated with COVID-19, from the acute to the chronic phase. Acquired Fanconi syndrome in patients with Legionella pneumonia. I put this paper in here to illustrate that a bacterial infection of the lungs can impact the kidneys. And Fanconi syndrome is a disorder involving the proximal tubules of the nephrons in the kidney. This is the site where calcitriol is primarily synthesized. It's estimated that about 85% of the circulating calcitriol in the serum, this key immune hormone, comes from the epithelial cells of the proximal tubules of the nephrons in the kidney. It's the mitochondria primarily in these cells which is synthesizing calcitriol, converting calcifediol into calcitriol. So when there's damage to the proximal tubules, either from microbial infections, aging, or from drugs, drug-induced Fanconi syndrome, these are all examples of acquired Fanconi syndrome. What is the treatment? Calcitriol replacement therapy. What is the agent that is used? Paracalcitol, because it is less calcemic than the endogenous hormone calcitriol. However, calcitriol replacement therapy using calcitriol is also a potential short-term strategy to treat patients who have acquired Fanconi syndrome. Now, shifting from a paper that was dealing with a bacterial infection inducing Fanconi syndrome, here is a case of a viral infection inducing it. West Nile virus neuroinvasive disease presenting with acquired Fanconi syndrome. which resolved on recovery. So this indicates that the Fanconi syndrome, which is acquired, there is impact on the proximal tubules, and they are not synthesizing calcitriol. They're also not importing electrolytes, and this gives characteristic signatures in the urine as well as in the blood. And again, this is being induced by a viral infection. So again, this is a case of acquired vitamin D resistance from microbial infections. Why do we use the term vitamin D resistance? It means that if you provide vitamin D3, the inactive nutrient, the metabolite which is synthesized in human skin, even if it's hydroxylated in the liver to calcifidiol, the kidneys have been impacted and they are not capable of converting calcifidiol into calcitriol effectively. This means this person who has acquired Fanconi syndrome is immunocompromised. They have acquired vitamin D resistance because no matter how much vitamin D3 you give them, their metabolic pathways, particularly the conversion of calcifidiol to calcitriol in the kidney, is impaired. So the takeaway clinical concept is there are multiple ways that acquired vitamin D resistance can be generated from microbial infections, and that should steer the strategies for the treatment of patients who have IACC conditions, including long COVID, because viral infections such as a West Nile virus infection can induce an acquired Fanconi syndrome. So in closing this YouTube, again, the key takeaway clinical concept is to think about acquired vitamin D resistance arising from microbial infections, whether it's a viral infection or a bacterial infection or perhaps even a protozoan infection like malaria or toxoplasma infections. This is a very recent review, news report, February 27th, 2026. Long COVID tied to elevated depression, anxiety risk, 3 years beyond infection. Adults experiencing long COVID may carry significantly increased risks of depressive and anxiety symptoms up to 3 years after initial severe acute respiratory syndrome coronavirus 2 infection, a SARS-CoV-2 infection, according to a population-based cohort study published in BMC Public Health. Psychological or psychiatric conditions. Notably, long COVID was linked to a 2.6-fold higher risk of depressive symptoms at the 3-year follow-up relative to no depressive symptoms at either visit. This means control. They're comparing the long COVID patients to. In addition, there is a 2.5-fold higher risk of anxiety at both follow-ups relative to no anxiety at either time point. And that is again in the control population. In the center of this slide, again, is this key review from 2025, the central role of macrophages in long COVID pathophysiology, emphasizing the M1 macrophage phenotype being persistently upregulated in long COVID patients. How can M1 macrophages be downregulated and M2 macrophages be upregulated? Potentially through the stimulation of vitamin D receptors, utilizing agonists such as paracalcitol, 125 vitamin D2. In a previous YouTube in this series, we have discussed how paracalcitol, by stimulating a vitamin D receptor, VDR, upregulates the cytochrome P450 enzyme CYP2J2. This is an epoxygenase which places an epoxy group on arachidonic acid. The lipids that are produced by the epoxygenation of arachidonic acid are known as EETs. EETs are very important in resolving inflammatory states by shifting macrophages from their M1 pro-inflammatory phenotypes to M2 anti-inflammatory phenotypes. M2 macrophages also secrete factors that prompt tissues to undergo healing responses. This is very important to heal injured microvasculature, which is common in long COVID because of the impact of microclots, as well as the infiltration of pro-inflammatory cell types such as M1 macrophages and neutrophils. It is especially important to attenuate inflammation, chronic inflammation in long COVID kidneys, because proximal tubules are the primary site for the biosynthesis and secretion of circulating calcitriol. So in closing, again, the takeaway clinical concept: acquired vitamin D resistance can arise from microbial infections, and it is likely to be a component of long COVID pathophysiology. The treatment for it is to utilize active vitamin D hormones, calcifediol and paracalcitol, to treat individuals who have acquired vitamin D resistance. Before moving to part 5 of this discussion, I invite you to go to a Google Docs folder. The link to that is highlighted at the bottom of the screen. Here you will find a PDF slide summary of this particular YouTube, which contains active links to other YouTubes on this channel. If you'll navigate to a subfolder, Download First, you will be able to find this YouTube PDF slide summary more quickly. You'll also find PDF slide summaries of recent YouTubes on this channel, for instance, a series on ferroptosis being driven by gene silencing. And in the YouTubes highlighted here as parts 1 through 3, we are discussing a key paper published in 2024, ferroptosis driven by GPX4 silencing via GPX4 promoter methylation. This involves hypermethylation of the GPX4 promoter, which is being induced by ischemic reperfusion injury in the liver. But this same mechanism is likely to occur elsewhere within the body. And this has particular importance for the impact of microclots, the ischemia that will result from the microclots. In addition, the reperfusion injuries that will occur when the microclots are dissolved with thrombolytic agents or with ultrasound. So preparing the tissues for the sudden reoxygenation and the production of reactive oxygen species, it's important to upregulate key antioxidant enzymes such as GPX4, and that can be done utilizing vitamin D receptor agonists such as calcifediol and paracalcitol. So these YouTubes discuss these issues, going into more of the molecular and cellular details of these potential therapies.